I want to talk about MCAS, mast cell activation
Yeah.
syndrome, but also Lyme, mold, all these things that most people, when they start having their symptoms, which are very unique to them, when go to the conventional doctor, and I've seen this many times, they get the very scary MS, they get the very scary, something else diagnosis, or, and suddenly it's a big deal we have to address. Whereas they move on to the functional practitioner. Oh, no, 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 that was MCA. That was Lyme disease, and let's treat it in a comprehensive nature. But isn't that part of the problem that there isn't much knowledge about these things within the conventional world?
Certainly, there's no understanding of complexity of multi-system, multi-symptom disease that micelle presents. Robert Naveau cell danger is because the silo-based gives, you dermatology, cardiology, respiratory, you
Right.
got all these diseases, nobody talks to each other. And they're all not wrong, but they're just not seeing that the root underneath it all is this defensive inflammatory mode that's got mast cells sitting in the middle of it.
Mm,
They can't tie the pieces together, and the patient just goes from pillar to post, beating their head against the wall, knowing that they're ill, but getting nowhere because they get. So I have a patient I'm working with now is, had psychiatric admission, 3 psychiatric
mm,
admissions. And she's educated and well informed, and she's not a psychiatric patient.
mm.
She's has, neuropsychiatric manifestations of chronic ill health, but she's not traditionally psychiatric per se.
If someone is listening to this, going through the gambit of what this can be and not understanding, being told all these different diagnoses that just don't seem even right to them, what is one to look out for with something like mast cell activation syndrome?
Well, mast cell activation syndrome, the mast cells, which are white cells that protect you against further invasion, but when they sense danger, they release these 1,000 mediators of inflammation. Or defense, ranging from histamine to proteases to chemokines to leukotrienes. So they sort of splatter like a shotgun, all these in multi-systems and multi-symptoms. And so it behooves a patient to try and look at, say, Dr. Afrin's book, Never Bet Against OCAM, or
Mm,
get a paper on. I've written blogs and things on what mast cell, how mast cells can present. And when they start seeing, oh, from a young age, I had irritable bowel syndrome, and then I had skin allergies, and then I had runny nose, and then I had, fibromyalgia, and then I had chronic migraines, and then I had endometriosis. And they see all of these symptoms that, over years have sort of been there. And then they get one trigger that then, like mold exposure, and they just get blasted into this multi-symptom plethora of symptoms, going from tinnitus to insomnia to migraines to shortness of breath to POTS and tachycardia and diarrhea, irritable bowel syndrome and joint pain and eczema. Once they start seeing multi-system, multi-symptoms across the board, they have to find themselves a mast cell specialist who can sort of put it all together and say, look, you have this chronic inflammatory condition. It's multi-system, multi-symptom, and you need to work your way through a step-like approach to managing it. And there is a hierarchy and a step-like approach to managing it. I use my own method over the years, which is establishing the health cycle principles, and then getting people to regulate their autonomic nervous system and their amygdala through either neurobiofeedback principles or SE practitioners, or many using some of the more DNRS programs, the primal trust programs, the Gupta programs, just self-regulating, cooling off their autonomic nervous system. And then I work with treating the circadian biology piece. They must learn about getting up with the sun and going to bed in darkness and getting rid of non-native EMFs and grounding. Then we work with diet and micronutrients. And then we work with POTS. You got to treat POTS before you go anywhere beyond anywhere else. If you don't treat POTS, you're not going to get a person out of it. And then you got to stabilize mast cells. And then you start stabilizing cell membranes and mitochondria, and then you do all the rest. I don't go near Lyme disease. I don't go near binders until we've established these hierarchy of symptoms and treatments based on this approach, you know. You go throw binders at somebody with mold exposure when they've got fatty acids that are low on the fatty acid test, -70, -80 of total lipid content, that person's going to crash their mitochondria because the cell membrane becomes further compromised. The binders bind fats that make up the cell membrane. So there's a hierarchy of interventions that are necessary.
And that's the thing, especially when you're talking about any complex chronic condition, it's the prioritization also of addressing certain things. People
Absolutely.
think, oh, I'll just, address the pathogen and that'll be enough. So we'll just go after that. But that's not usually, most of the time, the best case scenario. And everyone's different. How they have to peel back the layers of the onion will be different. So treatment protocols really make no sense in these type of things, correct? You got patterns, but not the particles.
There's no protocol that you can give. You have to know, you yourself have to know who you are to some extent, because you're going to be triggered by their response. You have to know who the patient is, and then you have to adjust your protocol to some extent according to their particular presentation. Some people, you may send them to do family constellation work before you go near the pathogen, because they're so dysregulated, and the charge that the unloved parent plays in their psyche is so huge. Unless they work through that, there's going to be no opening to get any other therapies to work. Won't work. You know? So you got to know the patient, you got to know their defenses, you got to know their particular. You also got to know what they're asking you to help them with. You have to be very sensitive to that. You know, what is it you want me to do? How do you want me to help you? And if they give you a broad mandate, then you have to present the broad mandate. Sometimes they have a narrow mandate. I had one guy come to see me, just want to know if my dizziness and my ringing in my ears is due to mold. Okay, we can do that. We'll do this. But he didn't want to know anything else. Fine. That's the mandate he gave me. We'll do that, you know.